Hello, my name's Matt Brown. I'm a faculty member at the UCSF Department of Radiology, and today I'm going to be speaking about computer-assisted decision systems in radiology. We're going to talk about the hope, some of the hype that occurred around this technology, and the hard truth of really where we are today. So to begin with, let's talk about computer-aided decision support in general. Computer-aided detection or diagnosis, also known as CAD for short, include various technologies including automated detection of abnormal objects, for example tumors, in an image, measurement of their characteristics or features, and from these diagnostic decisions can also be made, for example, as to whether that tumor is benign or malignant. Current paradigms using computer output tend to use this output as a second opinion. So the radiologist will review the scan first, make a decision, for example, about whether there are tumors present in the image, and only then turn on the computer output to provide a second opinion as to whether what they've seen is real or whether they've missed anything that's present in the image. Fundamental to use of CAD technology is CT image acquisition. CAD performance is determined to a large extent by the image acquisition. And it's very important to realize that CAD cannot be used in clinical practice without applying the appropriate imaging protocol. In fact, CAD systems should really specify the protocol requirements such as slice thickness, MAS, when they're going to be applied, because CT dose and noise can really affect the performance of the CAD system. It actually makes no sense to try and apply CAD unless image acquisition has been thought of in advance. So with that background an introduction, let's talk about the hope and initially the hype that built up around CAD technology. So the application that I'm going to focus on today is computer-aided detection of lung cancer. Lung cancer screening with CT has been shown to reduce mortality, and with multi-slice CT we now have the ability to acquire images at very fine spatial resolution, but this results in a lot of images to read manually, and I would argue there's pretty much too many to read manually in a routine screening setting. If you're acquiring with 10mm slice thickness, for example, you would get 40 slices through the chest approximately, but with 1mm scans you're going to expect about 400 images through the chest, and to detect smaller nodules and to use, you really want to have 1mm slice thickness. So given that you've got about 400 thin section images through the chest, computer assisted nodule and detection would really be almost a requirement if lung cancer screening is going to become widely available. There's just too many images to reliably screen large numbers of patients without computer assistance. So as an overview, CAD processing typically involves three main steps. The first one is image segmentation. In this step we identify regions or boundaries of objects of interest in the image. For example, in the setting of lung cancer screening, we would segment out the lungs, and then within the lungs we would identify all the attenuating structures. That would include blood vessels, airway walls, in addition to the lesions themselves. So at the image segmentation step we would extract out all of those different regions within the image. The next step is quantitative feature extraction, and that would include things like quantitative features that characterize the size, shape, attenuation of those segmented objects. And then would come the classification phase, where we would use those size and shape and attenuation features to make a decision about whether each region corresponds to a nodule that we are interested in or a blood vessel that we would want the CAD system automatically rule out. So to show that the CAD output in the form of an image, here you can see an original image on the left, and on the right you can see an automatically detected nodule. This is a ground glass lesion, and you can see that that lesion highlighted with an arrow and the segmented image boundary by the automated CAD system. Once those lesions are segmented and automatically detected, you can then volumetrically render and make measurements on that lesion, and the radiologist can then go and fill out an e-signature box. So this is roughly how the technology appears from the point of view of the radiologist. There have also been studies to assess the impact of a CAD system on reader performance, and so here's a little bit of a busy slide, but summarizing the output of the CAD system. So let's focus on the middle column, which looks at the performance of a non-thoracic radiologist. So you can see the middle column there on the left has their sensitivity per case before CAD and their sensitivity after the CAD system was turned on and they were allowed to detect any additional nodules that they agreed with from the CAD system. And if you look at the mean sensitivity, the top row there, you can see that it jumps from 0.62 without the CAD to 0.83 after the CAD. So a clear increase in their sensitivity for detecting nodules. And that's true also for the other columns, which are non-radiologists, and for thoracic radiologists. The thoracic radiologists who are more specialized in this area start out with a better performance before CAD, but they do experience some increase. So what this is telling us is that when they have the CAD output available, all the readers experience an improvement in their sensitivity, and they all start to approach the level of a more experienced reader. So you get some consistency where less experienced and less trained readers start to perform at the level of a more experienced reader, which is good. So this kind of result really fueled the hope and to some extent the hype that had really surfaced for a while around CAD technology. It looked so promising, and there seemed to be a lot of potential. I'd like to draw your attention now to a result in the middle of the slide. It's a number of false positive results per case. So a false positive is something that's marked in the image that turns out to be not actually a tumor. And so a false positive can have impact because it of course causes stress to a patient when you alert them to something that's not really an issue. It can also lead to unnecessary workups, further imaging, or an unnecessary biopsy, which introduce costs and potential morbidity for the patient. So you'll notice there that if you look across the mean number of false positive results per case for the non-thoracic radiologist in the middle, it went up from 0.25, so one false positive every four cases, to about 0.5, so one false positive every 2 cases. That doesn't sound like very much, and initially, during the phase of hype, it didn't really seem like a big deal. But really this was an indicator that there might be an issue here. When you think about screening hundreds or thousands of patients, that number of false positives is not insignificant. So now we get to, with that segue, to the hard truth. So this kind of result led to a lot of hype and enthusiasm, and a lot of papers were published. So here you can see a list of papers that were published from about 2004 through 2009. There are quite a number of papers. And so if you look at the sensitivity column, the 4th column along, there's quite a wide range in sensitivity here. Some of those sensitivities are pretty low. Some get down into the 50s and 60s, and a lot of them hover around 70% sensitivity. So, not terrible, but when you're trying to avoid missing a nodule, it's kind of low. You're trying to build a level of confidence in the radiologist that they haven't missed anything. Those numbers may be a little bit low. If we move one column over to the false positive rate, it ranges. CAD is finding anywhere from sort of 1 false positive per case all the way up to 8 false positives per case. And a typical number looks to be around 3, 4, or 5, maybe sort of around the 4 or 5. If you think about that in a busy screening setting, I'm a radiologist sitting down and I turn on the CAD, and every time I turn it on, I get alerted to some nodules, but my sensitivity is not great. But now I get highlighted 3 or 4 things that aren't nodules that I've got to rule out and worry about, am I missing something? So that level of false positive is really not useful to cut to the chase in a clinical setting. It's just too many. The other thing that I would point out about this data set, if you look at the third column along, the number of nodules, it varies widely. And if you go all the way across to the right, the CT section thickness varies quite a bit. And the nodule size which are included in the study varies quite a bit. So what that's telling us is that the data sets upon which the CAD systems were evaluated varied widely. So you really can't compare these CAD system performances because the size and the nature of the data set upon which they tested was really different. So to confound this even further, I see this range of performances. I really can't be sure that any one system is better than the other because they were all tested on different data sets. So to elaborate on those issues just a little further, you can see they summarized on the next slide here, which summarizes those issues. You have variable performance. We can't compare the CAD systems because of the differences, and in general they generate too many false positives. So they're highlighting normal anatomy like vascular or airway branches that are incorrectly detected by the CAD systems as nodules. These take time to rule out and can lead to unnecessary workups. If you look at the next image, you'll see this variability in slice thickness illustrated quite graphically here, and going from a 10mm to a 1mm scan. But even if you go from a 3mm to a 1mm scan, that spatial resolution really impacts the CAD performance dramatically. So you can't compare systems unless they have really consistently controlled for the slice thickness. If you look at the next image, which shows a rather noisy, grainy cross-sectional image, again you can see if people were using a very low dose compared to a standard dose, that's really going to dramatically affect the CAD performance and the difficulty of the CAD task. So unless that's taken into account, you cannot consider or compare across CAD systems. So this led us to the hard truth. With all these publications, CAD has not been adopted in clinical practice. As I said, this has been due primarily to inadequate performance levels, a lack of integration into the clinical workflow, and the necessary assessment tools to facilitate workup of these cases. Also an inability to limit false positive detections, and as I said, the difficulty in establishing the relative efficacy of the CAD systems. And this lack of standardization and evaluation criteria and in test data sets and their acquisition protocols has really hampered any kind of adoption in clinical practice. So the hard truth is that as we sit right now, there are CAD systems that have been purchased but are not being used really at all in clinical practice. They're basically in reading rooms, switched off, maybe under desks gathering dust for these very reasons that I've articulated. But I'd like to finish off with a few slides that talk about a return to the hope, because I think that there have been a lot of important lessons learned in the research and the attempts to deploy these systems clinically. And I think, as I've alluded to, image acquisition and considerations about dose and things like that are going to be critical as we take this forward. So let's get into some of those issues. So some of the things that have fueled returned interest in this area are some recent data, in particular from the National Lung Screening Trial, the NLST, which showed a mortality reduction from CT lung cancer screening. In parallel with this, over the last several years, the NIH has funded the Lung Imaging Database Consortium to put together a public CT image data set with annotated nodules, where the nodules have been identified by a panel of expert radiologists. And this data set is freely available on the web. So applying the NLST and Nelson, which is the European equivalent of the NLST, applying their nodule size criteria to this data set provides a CAD gold standard as well as a clinically based rationale for the kinds of nodules that we should be trying to detect. So now CAD has a better idea of what is important to detect in the images, and there is this publicly available data set that allows us to standardize our evaluations. So the NLST, as far as CAD targets, and the Nelson define positive or indeterminate CT screens as nodules that range in size from 4 up to 8 millimeters. So the newest versions of CAD are now being set to detect nodules that are 4 millimeters and larger. So with this in mind, we can turn our attention to what is the appropriate image acquisition protocol for a CAD system. Now, if we consider that the smallest symmetric three-dimensional filter is a 3x3x3 filter. So for a nodule to be detectable, we would want it to be present on at least 3 slices without partial voluming. And so if you look at this schematic here with a nodule of this size, which is 4 times the slice thickness, you'll see that those 3 innermost slices will capture the nodule without any partial voluming, and the slices with the dashed lines will be partial volumed. So if the nodule is 4 times the slice thickness, we will acquire it with at least 3 slices without any partial voluming. So that gives us a baseline for what imaging protocol is required for application of this CAD system. So in setting the image acquisition protocol, the minimum detectable nodule size will have dimensions greater than or equal to 4 times the slice thickness. So for detection of a 4 millimeter nodule, will require a slice thickness of 1 millimeter or less, and if you wanted to detect 8 millimeter nodules, you would require a slice thickness of 2 millimeters or less. The National Lung Screening Trial used slice thicknesses that were less than or equal to 2.5 by requirement for a site to be eligible to participate in the study, and they used a 20 to 80 effective MAS. So with these guidelines, it becomes important that the training and test sets for the CAD systems follow and are consistent with the clinical acquisition protocols that are going to be used. So with the latest versions of CAD systems, and here's one that we have developed at UCLA, when these image acquisition requirements are applied a priori and prospectively to the data set, the performance improves quite dramatically. So here's the sensitivity per patient. In this data set, there were 108 LIDC scans from the publicly available data set that we used. 44 of those patients had nodules, and 108 were available for false positive analysis. So for the 44 patients with nodules, we were able to compute a sensitivity per patient. The median sensitivity per patient was 100%, with the interquartile range becoming narrower, of course, as you include the larger of the nodules, which are the 8 millimeter size. For 4 millimeter nodules, the mean sensitivity was about 80%, and it was a little bit higher for the 8 millimeter nodules. So we are at the upper end of performances that were reported in the literature. But let's look at the table below, which is the false positive rate. You'll notice that the average number of false positives was 2 if we include nodules greater than or equal to 4 millimeters, and if we limit ourselves to the larger nodules of 8 millimeters, we're down to 1 false positive per case. So what we've done is achieved amongst the highest sensitivity but with amongst the lowest false positive rate that has been published. And getting down to that one, or hopefully no false positives per case, is going to be very important. And that 1 or 2 per case is the average. The median is 0 false positives per patient, meaning that for a typical case, you're not going to see any false positives. So we start to get closer to what would be clinically acceptable. And I'd just like to emphasize that this is in part due to improvements in the algorithm, but to a large extent due to standardization of the image acquisition. So I'll show you a range of sample true positive detections, and here you can see a range of different kinds of nodules that have been included. Irregular nodules, round nodules, nodules up against the chest wall, nodules in contact with vessels. So quite a range of nodules were detected by this CAD system. There were some false positives, and some of those false positives are due to bronchovascular anatomy, or even getting down towards the folds of bowel gas. Some of the false negatives, and there were very few false negatives, were nodules that were tucked up at the base of the lung. So really at the junction near the top of the diaphragm was a source of false negatives where there's room for improvement. If you look at the CAD results for volume, where you plot the true volume against the CAD volume on the vertical axis, you can see that there's very good agreement between the true volume as contoured by the expert radiologist and the volume measured automatically by CAD. So the size measurements from the automated CAD system look very robust, which is an important part of the necessary assessment tools. Once you've detected a nodule, for diagnosis and follow-up, it's critical to know and be able to track the size of that nodule. So an important part of CAD to be usable clinically will be to have reliable assistance in measurement. And it looks like we have the beginnings of that capability. So, in summary, CAD cannot be used in clinical practice without careful attention to the imaging protocol. We need to engage in task-based decisions relating to dose, because it's one thing when you're assessing dose to say, yeah, the image looks good. But if you've got a very specific task like CAD nodule detection, you can now objectively start thinking about looking at how low you could take that dose without affecting the performance of the CAD system. So there is a need, but also an opportunity to refine our decisions about what dose is appropriate, because we have an objective task here in CAD-assisted nodule detection. And so when you're considering screening where dose is of paramount importance, I think that considering how low you can take that dose while maintaining CAD detection performance will be critical. So with that, I'll conclude this lecture, and thank you for your attention.